Imagine a disease that's, well, famous for making your hands shake.
Right, the classic presentation.
Yeah, exactly. You probably picture those classic symptoms like a slight tremor in the fingers, or maybe a slower walking pace, or, a change in posture.
That is what most people visualize right away, yes.
But now, I mean, imagine sitting in a neurologist's office, getting that diagnosis, and eventually discovering that the absolute greatest threat to your life actually have nothing to do with your hands.
Which is a profound shock for most patients.
It really is, because the fatal blow is often something as mundane or like as entirely invisible as a single microscopic drop of water just going down the wrong pipe while you are trying to eat dinner.
Yeah, it really reframes everything.
It does. So today we're basically tearing up the script on what we think we know about Parkinson's disease.
It's a massive shift in perspective. And frankly, it's a necessary one.
Why is that?
Because the gap between what the public fears about this condition and what the clinical reality actually presents is just, well, it's massive.
Okay, let's unpack this. We're dedicating today's deep dive to the insights and medical realities surrounding the silent complications of Parkinson's.
The things no one talks about.
Exactly. Our mission here is to demystify mortality in progressive neurologic disorders. We're tackling one of the most common yet almost entirely unspoken fears surrounding a life-altering diagnosis, which is, can you actually die from Parkinson's disease?
That is a big question.
Right, because when you are terrified of something you don't understand, you're paralyzed by it. You just sit there and wait for the inevitable.
Right, the fatalism sets in.
Yeah, but when you actually understand how a disease operates over the long term, like the actual mechanics of it, the loopholes, you can take actionable steps. You can fight back.
Absolutely. Because knowledge is only truly valuable when it is understood and applied.
Preach.
And to apply it here, I really want to encourage you, as you listen today, to think critically about how we define something as seemingly simple as the cause of death in modern medicine.
Because it's not as black and white as people think, right?
Not at all. If you just look at raw mortality statistics, without the context of how those numbers are generated, you end up with a very distorted, unnecessarily terrifying picture of reality.
Which is the central mystery we are looking at today. Like, why do the raw statistics say one thing about Parkinson's mortality, while the reality on the ground, what neurologists and nurses actually see in the hospital, says something entirely different?
There's a disconnect there.
A huge one. It feels like there is a missing link between the diagnosis and the actual end of life.
That discrepancy is really the core of the entire issue we're diving into.
Okay, so where do we start?
Well, to understand it, we first have to establish the fundamental medical reality of what Parkinson's disease actually is, structurally, in the brain.
Right.
And just as importantly, what it is not.
Okay, what is it not?
Parkinson's disease itself is not considered a direct, sudden killer.
Like, it's not going to just strike you down out of nowhere.
Exactly. It is not a massive heart attack that stops the blood. It's not a ruptured aneurysm. It is not a severe stroke that instantly shuts down the vital organs.
So it's not a sudden catastrophic event where a switch just flips off?
Far from it. And this brings us to a vital distinction in medicine, particularly in geriatrics and neurology.
Which is?
The difference between dying from a disease versus dying with a disease.
Oh, I hear that phrase thrown around a lot, like dying with versus dying from, especially in the last few years.
It's become quite a buzzword, yeah.
But let's ground that. What does it actually mean in the context of Parkinson's?
Well,
Like, if someone has had this disease for 20 years and then they pass away, how does the medical community untangle what actually caused it?
what's fascinating here is that the biology answers that question long before the paperwork does.
Okay, break that down for me.
Parkinson's is fundamentally characterized by the depletion of dopamine in a very specific tiny area of the brain called the substantia nigra.
The substantia nigra.
Yes, which sits in a region called the basal ganglia. Now, dopamine is a neurotransmitter.
A chemical messenger.
Exactly. And in this specific brain circuit, it acts sort of like the oil in an engine. It allows for smooth, coordinated muscle movements.
So when that runs out?
When that dopamine is depleted, you get the classic symptoms, the tremors, the rigidity, the slowness of movement.
Which is what everyone sees, the outward motor symptoms.
Yes, but here is the crucial anatomical fact that often gets completely lost in the fear of the diagnosis.
What's that?
That specific dopamine depletion of the basal ganglia does not stop your heart from beating.
Wait, really?
It does not stop your lungs from drawing in air.
Yeah.
The basal ganglia just does not control those baseline involuntary life support functions.
Because those are controlled somewhere else.
Yes, they're controlled much lower down at the base of the skull in the brainstem.
Okay, the brains?
The brainstem is like the primitive autopilot of the human body. The substantia nigra can be profoundly depleted of dopamine, drastically altering your voluntary movement, but the brainstem just keeps humming along.
Telling the heart to pump.
Telling the heart to pump, telling the diaphragm to contract. The disease itself, structurally speaking, just doesn't pull the plug on the central power grid.
So the brainstem is still doing its job. The heart beats, the lungs breathe. The disease isn't the direct killer.
Correct.
But if that's the case, why does Parkinson's show up on so many death certificates? Like, if I go look up CDC mortality data right now, Parkinson's is listed as a major cause of death.
It is, yeah.
So how does that happen if the biology doesn't support it stopping the heart?
This is where the clinical reality meets the bureaucracy of death.
The bureaucracy of death. Wow, okay.
When a patient passes away, an attending physician has to fill out a death certificate, right?
Right.
And this document have multiple lines. The top line is the immediate cause of death. Let's say acute respiratory failure.
Okay, that makes sense.
Then there are subsequent lines for underlying causes that initiated the chain of events leading to that immediate cause.
Gotcha.
And finally, there's a whole separate section for other significant conditions contributing to death.
Ah. It sounds like a hierarchy of blame.
That's a great way to put it. It is an attempt to paint a complete historical picture of the patient's health status at the end of life.
So they want to capture everything going on.
Exactly. If a patient has lived with advanced Parkinson's for 2 decades, it has profoundly impacted their body. So, the physician will almost certainly list Parkinson's somewhere on that certificate as a contributing or underlying factor.
Even if it didn't directly stop the heart, it's just too big a piece of their medical history to leave off the page.
Precisely. Now, imagine public health researchers aggregating millions of these death certificates to generate national mortality statistics.
Oh, I see where this is going.
They sweep up all those mentions of Parkinson's. The statistics capture the heavy presence of the disease, but in doing so, they completely blur the actual mechanical mechanism of mortality.
I see. It's like we're confusing the environment someone lived in with the actual event that took their life.
That's a perfect summary.
Let me try an analogy here to make sure I'm wrapping my head around this. Having Parkinson's is kind of like living in a house with a slowly degrading foundation.
Okay, I like that.
The foundation itself, as it weakens, doesn't actually crush you. Like, you could theoretically live in a house with a bad foundation for decades.
Right.
It just means, the floors are uneven and the doors stick.
A very apt comparison.
But because the foundation is shifting and weak, it causes the roof to warp over time. It creates structural stress everywhere.
Yes.
And then a heavy storm hits. The roof caves in during the storm. It's the storm, the complication, that does the damage and actually hurts you.
Exactly.
But the weak foundation made that damage inevitable. It set the stage for the storm to be catastrophic.
That is a brilliant way to visualize it. The Parkinson's is the degrading foundation.
Yeah.
It creates a state of systemic vulnerability throughout the entire body. It doesn't strike the fatal blow, but it makes the house incredibly susceptible to the elements.
Okay, but I want to push back on this a little bit.
Sure.
If I am a patient and I hear a doctor say, well, the good news is the disease won't kill you, but the complications will, I might think, what difference does it make?
Yeah, it sounds a bit hollow.
Exactly. Isn't that just a distinction without a difference? Are we just arguing semantics here to try and soften the blow of a really heavy diagnosis?
I completely understand why it feels that way upon first hearing it, but I assure you it is not just semantics.
Okay.
What's fascinating here is that this distinction between the foundation and the storm is the absolute cornerstone of how modern medicine approaches neurodegenerative patient care.
It is.
Yes, it changes the entire paradigm.
Walk me through that. Like, how does it actually change the treatment?
Think about your house analogy again. If you truly believe the foundation itself is going to eventually leap up and crush you, you might just despair and give up, because you can't magically pour a new foundation while you are actively living in the house. In medical terms, we cannot currently cure Parkinson's disease or reverse the loss of those dopamine-producing neurons.
So if the disease itself is the direct killer, you are just waiting for the end.
You're just sitting on the couch waiting for the floor to drop out. Exactly.
That's incredibly bleak.
But if you understand that the actual danger is the roof caving in during a storm, your entire strategy changes.
You don't just stare helplessly at the foundation.
Exactly. You reinforce the roof to install better drainage. You stockpile supplies for the storm.
You shift your energy from the incurable foundation to the highly preventable complications.
That is the turning point in patient care right there. If we know the foundation creates systemic vulnerability, we stop viewing the progression as this unstoppable mystical march toward death.
We take back some control.
Instead, we actively identify the specific storms that are going to take advantage of that vulnerability. We shift from a mindset of fatalism to a mindset of strategic defense.
Strategic defense. I love that framing.
It changes everything for the patient.
Because if Parkinson's is creating this vulnerability, the next logical step is to map out the threats. We need to look closely at what those specific storms actually are.
Precisely.
What are the external or internal elements that are going to test that weak foundation?
And there are several major ones.
Right. So let's talk about the most dangerous, yet probably the least talked about complication revealed in our sources. We really need to talk about swallowing.
Yes. This is perhaps the sharpest divergence between public perception and clinical reality.
I mean, when people think of Parkinson's, they think of limbs.
They think of the hands, the legs.
Yeah. But the sources highlight dysphagia, which is the medical term for swallowing difficulties and aspiration, as these massive life-threatening vulnerabilities.
They absolutely are.
Which is wild to think about, because if my hand shakes, it's frustrating, sure. It might stop me from writing a letter or holding a coffee cup. But it doesn't threaten my life.
No, it doesn't.
So why does a disease characterized by limb tremors affect your ability to safely eat a bowl of soup?
It comes back to redefining what a movement disorder actually entails.
Okay.
We take swallowing completely for granted. I mean, you probably swallowed a dozen times since we started talking.
I just swallowed right now thinking about it.
Right. But physiologically, a swallow is an astoundingly complex, highly coordinated sequence of muscular events.
Really? It feels so simple.
It requires roughly 50 pairs of muscles and multiple cranial nerves working in perfect harmony in a fraction of a second.
Wait, 50 pairs? Just to get water down to the stomach?
Yes. It's incredibly intricate. You have the oral phase, where your tongue and jaw chew and manipulate the food into a bolus.
Okay. Chewing makes sense?
Then the pharyngeal phase, where the food actually moves down the throat. Now, this is the danger zone.
Why is it a danger zone?
Crucially, your airway, the trachea leading to your lungs, sits right in front of your esophagus, which leads to your stomach.
Right, they're right next to each other.
When you swallow, an intricate reflex arc causes a little flap of cartilage called the epiglottis to slam shut over your windpipe.
Oh, to cover the lungs.
Exactly, so the food goes into the esophagus and not down into the lungs.
It's essentially a highly choreographed, high-speed dance of muscles.
A dance that happens entirely subconsciously in a healthy person. But remember what Parkinson's actually does to muscle tissue.
It makes it rigid.
It causes bradykinesia, which means slowness of movement, and it causes muscular rigidity.
Right.
We easily recognize this in a shuffling gait or a stiff arm. What is completely hidden from view is that the exact same bradykinesia and rigidity are happening to the microscopic muscles of the tongue, the pharynx, and the esophagus.
Wow. So the throat muscles are moving just as slowly and stiffly as the arm muscles. The rigidity isn't just confined to the outside of the body.
Not at all. The internal muscles are suffering the exact same dopamine deprivation.
Oh, man.
So the coordination of that muscular dance becomes delayed. The epiglottis, that vital little flap that is supposed to seal off your windpipe,
It doesn't close in time.
it might be a fraction of a second too slow to close.
And if it's too slow, the trap door is basically open while the food is moving past.
Yes.
That's when aspiration happens.
Exactly. Aspiration is the medical term for when food, liquid, or even just your own saliva bypasses the epiglottis, goes down the wrong pipe, and enters the airway.
Yikes.
Now, we've all experienced this mildly, right?
Oh, yeah.
You take a drink of water, you laugh, it goes down the wrong way, and you cough violently for 2 solid minutes, eyes watering, just to clear it out.
It's awful, but the cough usually fixes it. You catch your breath eventually.
Exactly. That explosive cough reflex is your body's alarm system. It is a violent, necessary defense mechanism to keep the lungs clear.
Okay, so a Parkinson's patient aspirates, they cough it up. What's the big deal?
Well, the sources point out something incredibly dangerous regarding Parkinson's. It's called silent aspiration.
I was actually reading about that in the prep. The phrase itself sounds incredibly ominous. Silent aspiration.
It is ominous.
What makes it silent? Does the person just not know how to cough anymore?
It is far more insidious than just losing the physical ability to cough.
How so?
Parkinson's disease doesn't just affect the outgoing motor nerves that tell muscles to move, it can also severely blunt the incoming sensory nerves that send feeling back up to the brain.
Wait, really? It affects sensation, too.
Yes, in advanced Parkinson's, the sensory feedback lining the throat can become incredibly muted. It basically goes numb.
Oh my God.
So a patient can inhale food or liquid directly into their trachea, and they literally do not feel it happening.
That is terrifying. So the alarm system is just completely disconnected. There is no violent coughing fit.
None. They aspirate entirely silently.
That's wow.
They could be sitting at the dinner table looking completely comfortable, having a normal conversation with their family, while microscopic particles of their dinner are falling directly into their lungs.
Okay, but let's follow that down. A crumb of bread or a drop of water gets into the lung. Is that an immediate emergency, or does the body just absorb it?
It triggers a devastating chain reaction.
Because of bacteria.
Yes. The human mouth is absolutely teeming with bacteria. Even with perfect dental hygiene, the oral microbiome is incredibly dense.
Right?
When you inhale food or liquid, you are dragging that oral bacteria directly down into the delicate, sterile tissues of the lungs.
And the lungs are not meant to handle that.
Not at all.
Yeah.
The lower lungs are a warm, dark, moist environment. It's an absolute paradise for bacterial growth. This directly seeds the lungs with infection.
And that leads to pneumonia.
Specifically, aspiration pneumonia.
Wow. If you are listening to this right now, I really want you to pause and think about the reality of what we are discussing.
It's a heavy realization.
It really is. You think of Parkinson's as a limb-shaking disease. You worry about losing the ability to play the piano or write a check or walk your dog.
Which are all valid fears.
Absolutely valid. But historically, one of the leading actual causes of death for Parkinson's patients isn't related to their limbs at all.
No, it's not.
The fatal blow often comes from a microscopic drop of water going down the wrong pipe completely unnoticed while they are just trying to stay hydrated.
It completely reframes the danger.
It really does.
And aspiration pneumonia is not just a mild chest cold. It is a fierce, aggressive, necrotizing infection.
Necrotizing.
It destroys tissue. In a younger, healthier person, the immune system might mount a massive inflammatory response and fight it off.
They have the energy for it.
Right. But in an elderly patient whose entire physiological system is already strained by the massive energy demands of Parkinson's, aspiration pneumonia can be rapidly fatal.
It is the classic storm hitting the weak foundation.
Exactly.
And beyond the infection risk, I just think about the mental toll. Imagine having to consciously orchestrate every single muscle involved just to drink a glass of water.
It's exhausting.
I mean, imagine having to focus all your mental energy on making sure the water goes into your stomach and not your lungs every single sip.
The fatigue is immense.
I can't even imagine.
The mental effort required to perform biological functions that used to be automatic drains the patient's cognitive and physical energy over time, which just contributes to overall decline.
So silent aspiration shows us how the internal breakdown of muscles threatens the lungs.
Yes.
But what happens when that exact same muscular failure interacts with the physical world outside the body? Let's talk about gravity.
Gravity, the constant opponent.
Right, because if aspiration brings the danger deep into the chest, then gravity brings the danger to the entire human skeleton.
We are moving from the invisible threat of swallowing to the very visible, highly traumatic threat of falls and immobility.
And this is a danger that most people are at least tangentially aware of, right? Like, everyone knows falling is bad.
They do, but they vastly underestimate the mechanical reality of it and the clinical aftermath.
I think everyone knows elderly people are at risk of falling. You see the alert buttons advertised on TV all the time.
Right, I've fallen and I can't get up.
Exactly. And everyone knows Parkinson's affects your balance, but surely a Parkinsonian fall isn't the same as someone just tripping over a loose rug in the hallway.
It is neurologically entirely different.
How so?
Well, if a healthy person trips over a rug, their brain detects the shift in gravity instantaneously. Before they even consciously register what happened, their intact reflexes take over.
Right.
Your arms instinctively shoot out to catch yourself.
Yep.
Your leg rapidly steps forward to widen your base of support and catch your center of mass. You automatically twist your torso to protect your head.
These are called righting reflexes.
Exactly. They are automatic survival programs hardwired into the brain.
So what happens in Parkinson's?
Parkinson's disease fundamentally dismantles these righting reflexes.
Wait, is that just because they move slower? Like the arms just don't shoot out fast enough because of the bradykinesia?
The bradykinesia plays a role, yes. The reaction time is sluggish. But it is much deeper than that. It's a profound loss of postural stability. The brain's subconscious ability to calculate where the body's center of gravity is in space and constantly microcorrect it just deteriorates.
So they literally lose their sense of balance at a base level.
Yes. Furthermore, Parkinson's patients frequently experience a phenomenon called freezing of gait.
Freezing of gait. I've actually seen this.
Have you?
Yeah, my grandfather had Parkinson's, and I remember walking with him once. We were moving along fine, just a slow shuffle, and suddenly it was like someone hit pause on a remote control, but only for his feet.
That's very common.
He pitched completely forward. It was terrifying to witness because it happened so fast.
That is a textbook description of freezing of gait. Patients describe it as feeling like their feet are suddenly magnetized or super glued to the floor.
Yes, that's exactly what it looked like.
They intend to step forward, their motor cortex sends the signal, but the signal gets jammed in the damaged basal ganglia. The legs simply do not move.
Wow.
Now think about the physics of walking. You have forward momentum.
Right, your upper body is moving forward.
Suddenly your base of support, your feet, stops dead. But the upper half of your body, your torso and your head, still have all that forward momentum.
You're going to topple right over like a felled tree.
Precisely. You pivot straight over your own ankles. And because those righting reflexes we discussed are impaired, the arms don't shoot out to break the fall.
The head doesn't tuck in.
Exactly. The patient impacts the ground with full force. This isn't a slow, sliding slump to the floor. It's a hard, traumatic, high-velocity impact.
And that impact is just the beginning.
Just a beginning.
I want to trace the cascade effect here, because a fall in this population isn't just an isolated event resulting in a few bruises.
Rarely.
According to the medical realities we're diving into, a severe fall is the first domino in a very dangerous, life-threatening sequence.
Let's trace it.
Okay.
Let's imagine a patient suffers this exact type of fall and fractures their hip, which is highly common due to the angle of the fall. A broken hip in an elderly patient is agonizing and requires immediate surgical intervention. To repair a hip, you require general anesthesia.
And I'm assuming general anesthesia on a brain that is already compromised by Parkinson's is a massive risk.
It is a profoundly delicate situation. The brain is already struggling to maintain chemical equilibrium. When you introduce heavy anesthetic drugs, the delicate balance is totally shattered.
What happens?
It frequently causes severe postoperative confusion, acute delirium, and in some cases, a sharp, permanent decline in cognitive baseline.
Permanent.
Sometimes, yes. The patient might wake up from the surgery and never fully return to the mental clarity they had the day before the fall.
That alone is a tragedy.
It is heartbreaking.
But let's say they get through the surgery, the hip is pinned, the anesthesia clears up, they are in recovery.
The aftermath of the surgery is where the true long-term danger lies.
Because they have to stay in bed.
Yes. To heal a pinned hip, the patient requires strict bed rest. And this introduces one of the most terrifying concepts in all of geriatric medicine.
The immobility spiral.
The immobility spiral.
That sounds like a vortex you do not want to get caught in. Break that down for us. Why is simply lying in a hospital bed so dangerous? I mean, you're resting, aren't you?
You're resting, but the human body is entirely designed for movement. It relies on movement to function at a basic cellular level.
Right.
When you place an elderly person, especially one with a neurodegenerative disease, on strict bed rest, the physiological deterioration is exponential. It happens faster than anyone expects.
How fast?
Muscle atrophy begins within 48 hours.
In just 2 days.
Yes. The muscles, deprived of gravity and use, literally begin to waste away and reabsorb into the body.
That is shockingly fast.
And it cascades. The bones, no longer bearing weight, begin to rapidly lose density, setting up for future fractures.
It's like astronauts in space.
Very similar mechanism, yes. Furthermore, because the patient isn't walking, the calf muscles aren't acting as pumps to push venous blood back up to the heart.
So the blood just sits there.
Blood pools in the lower legs. This puts the patient at a massive risk for deep vein thrombosis blood clots.
And if a clot breaks loose?
If it breaks loose and travels to the lungs, it causes a pulmonary embolism, which is frequently fatal.
Wow. So the cardiovascular system starts to fail just from being horizontal.
Yes.
What about the skin? I hear about bed sores a lot in nursing homes.
Pressure ulcers, or bed sores, are a devastating part of the spiral. If a patient is immobile and lacks the strength to turn themselves in bed every 2 hours, the constant pressure of their own body weight against the mattress crushes the tiny capillary blood vessels.
The blood supply gets cut off.
Exactly. Feeding the skin over bony areas like the tailbone or heels Deprived of oxygenated blood, the tissue literally dies and rots away.
And that's horrifying.
These ulcers can become massive, deep wounds that expose bone, leading to bone infections and eventually systemic sepsis.
Okay, so let's trace the dominoes here.
You do.
A momentary freezing of gait led to a fall,
Yes.
which broke a bone,
Yes.
which required surgery, which mandated bed rest.
Right. Which rapidly evolved into severe muscle wasting, deadly blood clots, and rotting skin.
That is the tragic, silent reality of the disease progression.
I have to ask about the psychological side of this.
It's a huge component.
If I am a Parkinson's patient and I am aware of this entire cascade, I am going to be utterly terrified of falling.
Actually.
I think, if I walk to the kitchen and fall, I could end up with a bed sore that kills me.
Mm-hmm.
So I might decide, you know what, I'm just going to sit in my recliner all day. I'll ask my spouse to fetch things for me. It's safer.
A very common, very human reaction.
But if a patient stops moving to avoid a fall, aren't they just triggering that exact same immobility spiral on their own?
You have just articulated one of the most difficult, heartbreaking catch-22s in Parkinson's care.
It's a trap.
We have a clinical term for it. Kinesiophobia, the intense fear of movement.
Kinesiophobia.
The psychological trauma of a previous fall, or just the fear of a potential one, creates a state of self-imposed immobility.
By desperately trying to protect themselves, the patient voluntarily stops walking. In doing so, they rapidly strip away their remaining muscle strength, their cardiovascular endurance, and the flexibility of their joints.
Which means that when they inevitably do have to get up, because eventually you have to get up to use the bathroom or get to a doctor's appointment, they are vastly weaker than they were before.
Exactly. And therefore, they are much more likely to fall and much more likely to suffer a catastrophic injury when they do.
The self-imposed immobility guarantees the very outcome they were trying to avoid.
Sadly, yes.
Yeah.
The house foundation gets exponentially weaker because nobody is walking on the floors to maintain them.
So the physical breakdown is compounding at an alarming rate here. We have poor nutrition and potential lung infections because of the swallowing issues.
Yes.
We have muscle wasting, cardiovascular decline, and skin breakdown because of the immobility.
Correct.
This isn't just about localized problems anymore. This is opening the gates for complete system-wide failure.
It is systemic vulnerability.
Which brings us to a crucial concept regarding how the body fights back. How does all of this breakdown set the stage for life-threatening infections and overall frailty?
Well, we mentioned aspiration pneumonia earlier, which attacks the lungs. But that is only one battlefront in the war against infection.
What's the other one?
The other major systemic source of infection in Parkinson's and in advanced age in general is the urinary tract.
Urinary tract infections, UTIs.
Yes. They are incredibly common and deceptively, aggressively dangerous in this population.
Deceptively dangerous. I feel like most people think of a UTI as a nuisance.
They do.
Like you get some burning, you go to urgent care, you get a quick prescription for antibiotics, maybe drink some cranberry juice, and you're fine in 3 days.
For a healthy 30-year-old, yes.
Why is it so much worse here?
First, consider the mechanics of why they happen so frequently. We just talked about immobility.
Right.
Immobility makes basic personal hygiene significantly more difficult for the patient and the caregiver.
That makes sense.
Furthermore, the widespread neurological changes of Parkinson's eventually affect the autonomic nervous system, which controls smooth muscles, including bladder function.
So the bladder gets rigid, too.
The bladder muscles become rigid or uncoordinated. When a patient tries to void, the bladder may not empty completely.
Wait, so if the bladder is stagnant, the bacteria just sit there, like standing water in a pond?
That's a great way to put it. Standing water breeds mosquitoes. A stagnant, warm bladder breeds E. coli and other bacteria at an exponential rate.
Oh, gross. But I get it.
So the infections happen constantly.
Okay, I understand why they get them more often, but why are they so dangerous?
The danger lies in how an older, neurologically compromised body responds to the presence of that bacteria. In a younger person, a UTI causes local pain and urgency, the burning sensation you mentioned. That pain is a warning signal.
Right, it tells you to go to the doctor.
But in an older, compromised patient, a UTI frequently presents without any local pain or burning whatsoever.
Wait, no warning signal at all?
None. Instead, the very first symptom a caregiver might notice is sudden, severe, terrifying delirium.
Delirium from a bladder infection.
Yes. The patient, who was perhaps totally lucid at breakfast, may suddenly begin to hallucinate vividly. They become intensely agitated, confused, paranoid, or they might completely lose consciousness.
Let's slow down here. This is wild. How does a localized bacterial infection in the bladder end up causing severe hallucinations?
It seems like a huge leap, doesn't it?
It does. I mean, the brain has a security fence, the blood-brain barrier. How does a UTI breach that fence and hijack the brain?
It is a devastating issue of systemic inflammation.
Okay, inflammation.
When the bacteria multiply in the stagnant bladder, the body's immune system detects them and triggers a massive systemic alarm.
Sending in the troops.
Right. Immune cells called macrophages release chemical messengers called inflammatory cytokines into the bloodstream. They are yelling for help.
Got it.
Now, in a young, healthy person, the blood-brain barrier is tight and secure. It keeps those inflammatory chemicals completely out of the brain.
But in an older person with Parkinson's.
The blood-brain barrier is worn down. It is more permeable, like a fence with holes in it.
Oh, no.
Those inflammatory cytokines flood across the barrier and directly into the brain tissue. This causes acute neuroinflammation.
The brain literally gets inflamed.
Yes, and that dramatically disrupts the already fragile dopamine networks. This manifests as acute encephalopathy, or delirium.
So the hallucinations are a symptom of an inflamed, overwhelmed brain sparked by a bladder infection.
Yes, and if the UTI is not caught immediately, like if the caregiver assumes the confusion is just, the Parkinson's getting worse and doesn't get a urine test, the bacteria will rapidly enter the bloodstream.
Which leads to?
This causes sepsis. Sepsis is a cascading, overwhelming immune reaction that drops blood pressure to lethal levels and rapidly shuts down the kidneys, the liver, and the heart.
If you're listening to this and thinking about an older parent or grandparent who's suddenly acting confused or seeing things that aren't there, this is why doctors always ask for a urine sample first in the ER.
Always. It's the very first thing we check.
It's not a coincidence. It is an immediate attempt to rule out this exact systemic cascade.
Exactly.
And this entire concept of vulnerability really hinges on a word that gets used casually in everyday conversation, but has a very specific, critical medical meaning here.
Yes, frailty.
We need to talk about frailty.
This is paramount to understand. Frailty is not just an adjective you use to describe someone who looks thin or moves a bit slowly.
Right.
In geriatrics, frailty with a capital F is a formally defined clinical syndrome.
A syndrome.
Yes, it is characterized by a severe systemic loss of physiological reserve.
Physiological reserve, like a backup battery for the human body.
Exactly like a backup battery.
Right.
Let's use a financial analogy to make it clearer.
I love analogies. Go for it.
Think of your body's energy, immunity, and resilience as a financial savings account.
Okay.
A healthy, robust person has a massive rainy day fund. If they get the flu, which is the biological equivalent of an unexpected major car repair, they just pay to fix it out of their massive savings.
They absorb the cost.
Right. They feel crummy for a week, but their life continues normally. They absorb the shock.
They have the reserve to handle the hit.
Exactly. But a frail person, a patient deep into the progression of Parkinson's, is living physiologically paycheck to paycheck.
Oh, wow.
Their cellular savings account is at absolute zero. It takes 100% of their available daily energy just to maintain baseline homeostasis, just to keep the heart pumping, to try and digest food, to force rigid muscles to take a step.
So if they hit a bump in the road,
If they get a minor UTI or a cold or they miss a meal, another biological car repair bill, they don't have the reserve to fight it. They can't absorb the shock.
what happened?
Their entire physiological system crashes. They go entirely bankrupt.
This brings up a critical question about the immune system itself.
Okay.
If someone with Parkinson's is so uniquely vulnerable to pneumonia and sepsis, is the disease actively attacking their white blood cells?
That's a great question.
Like, is Parkinson's fundamentally an autoimmune disease like HIV that actively seeks out and destroys the immune system? Or is the immune system just exhausted from dealing with the rest of the body's breakdown?
Clarifying this is essential. Parkinson's is not an autoimmune disease that directly suppresses or attacks the immune system.
Okay, that's good to know.
The white blood cells, the soldiers of the immune system, are still there in normal numbers waiting to do their job.
So why are they failing so spectacularly against a basic bladder infection?
The immune weakness is entirely secondary. It is a devastating byproduct of the physiological bankruptcy we just discussed.
The zero balance in the account.
Exactly. How can your immune system mount a fierce, energy-intensive fever to burn out a virus if you are severely malnourished because you can't swallow properly?
You don't have the calories to burn.
Exactly. How can your lungs physically expel invading bacteria if the rigid chest muscles of Parkinson's prevent you from taking a deep breath or coughing forcefully?
The mechanics are broken.
Right. And how can your bone marrow produce the energy to fight sepsis if you are physically exhausted from the constant tremors and the effort of moving against rigid muscles all day long?
It's like having a well-trained, fully equipped army, but cutting off all their supply lines, taking away their rations, and forcing them to fight in the dark, uphill.
That is exactly right.
They are going to lose, not because they aren't capable soldiers, but because the environment they are fighting in is completely hostile to their success.
The immune system isn't structurally broken. It is simply deprived of the fuel and the mechanical assistance it needs to operate.
That is so tragic, but so illuminating.
And this understanding is the crucial pivot point for how we actually treat the disease in modern medicine.
The shift in strategy we talked about earlier.
Yes. If the true causes of mortality in Parkinson's are actually these secondary complications, the aspiration, the falls, the infections driven by frailty, then the way we fight back has to change entirely.
We can't just throw pills at the foundation.
We cannot just rely on a pill to replace dopamine. We have to change the entire battlefield.
Which opens up a completely new horizon for care. If we know the specific traps in the maze, the swallow, the fall, the stagnant bladder, how do we guide the patient around them?
It takes a village, honestly.
This isn't just about managing a chemical deficit anymore.
No, it requires a complete paradigm shift. For a long time in neurology, the focus was almost entirely pharmacological.
Just drugs.
Yes. A patient is diagnosed, the neurologist prescribes levodopa to replace the missing dopamine. They adjust the dosage as the disease progresses over the years, and that was essentially the core of the treatment.
Just trying to keep the chemical scales balanced.
Exactly. But as we've established, managing dopamine levels in the brain does not stop the immobility spiral once a hip breaks.
No, it doesn't.
And it certainly doesn't teach a patient how to swallow a glass of water safely when their throat goes numb.
A pill cannot fix a purely mechanical failure in the home.
Never. We need a multidisciplinary approach.
Okay, who's on the team?
Well, the neurologist is the quarterback of the team. Absolutely essential. But you cannot win the game without the rest of the players on the field.
Who are the other players?
We are talking about allied health professionals who actively step in to manage disease progression and fiercely protect the quality of life.
Let's walk through who is actually on that team, because these are the people doing the vital work of fortifying the house against the storm.
They are the builders.
Let's start with the swallowing. The invisible threat of silent aspiration. If a neurologist's pills can't fix it, who steps into the room to save the lungs?
That is the domain of the speech-language pathologist, or SLP.
A speech-language pathologist.
Yes.
Yeah.
And their role in neurodegeneration is far broader and more critical than just helping people speak loudly, although managing vocal cord rigidity is part of it.
Because they're the experts on the throat?
An SLP is an absolute expert in the intricate mechanics of the throat. If a patient is coughing at meals or getting recurrent chest infections, the SLP will conduct in-depth swallowing studies.
How do you study a swallow? Like, you can't just look down their throat with a flashlight while they eat a sandwich.
No, you can't.
Yeah.
They use a remarkable piece of diagnostic imaging called a modified barium swallow.
Modified barium swallow.
The patient sits in front of a live, continuous X-ray machine called a fluoroscope.
Oh, so a video X-ray.
Exactly. They are given different consistencies of food and liquid, from thin water to thick pudding, that are mixed with barium.
What does the barium do?
Barium is a contrast agent that glows stark black on the X-ray monitor.
So the SLP can watch the exact muscular mechanics of the swallow in real time, right on the screen.
Exactly. They watch the barium bolus move in slow motion. They can see exactly where the failure is occurring.
That's incredible.
They can ask, is the tongue too rigid to push the food back? Is the epiglottis closing a fraction of a second too late? Is the fluid splashing over the airway and trickling down into the trachea, confirming silent aspiration?
They literally see the water go into the lungs. Okay, so if the throat muscles are failing and they see the water going into the lungs on the X-ray, a neurologist prescribing more dopamine clearly isn't enough. I'm assuming you need some kind of physical therapy for the throat.
In a way, yes.
How do they fix mechanical failure like that?
They teach highly specific mechanical compensatory techniques.
Like what?
For example, a common intervention is the chin tuck maneuver.
The chin?
By simply having the patient consciously tuck their chin down to their chest immediately before they swallow, they physically alter the anatomy of the throat.
Tucking the chin changes the throat that much.
It does. It mechanically narrows the airway entrance and widens the space for food to safely go down the esophagus.
Wow.
It drastically reduces the physical space for aspiration to occur.
That is fascinating. It's a purely architectural fix to a neurological problem.
Yes, exactly. And if the muscular mechanics are simply too degraded to fix with posture, the SLP might prescribe altered liquid diets.
Altered liquids, like thickening the water. I've seen those little packets in hospitals.
Yes, thickened liquids. Thin liquids, like water, coffee, or juice, are the most dangerous things for a Parkinson's patient to consume
Because they're fast.
because they move incredibly fast. If your throat muscles are bradykinetic and slow, the water splashes into your airway long before the protective flap can close.
It literally outruns the defenses.
It outruns the defenses. By adding a specialized thickening powder to the liquid, you alter its viscosity to the consistency of nectar or even honey.
Oh, honey-thick water. That sounds weird.
It takes getting used to, but the thickened liquid moves much, much slower.
So it buys time.
This simple physical change gives the rigid, delayed throat muscles the critical extra fractions of a second they need to coordinate the swallow and close the airway safely.
That's amazing.
It's a simple physical intervention that literally saves lives by preventing pneumonia.
So the SLP protects the lungs. They fortify the internal plumbing.
Exactly.
But what about the external threats? What about the falls, the freezing of gait, the immobility spiral? Who takes point on keeping the patient vertical?
That is the domain of the physical therapist, the PT.
Okay, PT.
But it is crucial to understand that this isn't just generic exercise or walking on a treadmill. A neuro-PT trains the patient specifically for the unique deficits of Parkinson's.
Right, because their balance system is broken.
They teach highly specific fall recovery techniques.
Wait, teaching them how to fall, isn't the goal not to fall?
The goal is prevention, yes, but acknowledging the reality of the disease means preparing for the worst.
So you assume they will fall.
You prepare for it. They literally train a patient on a mat on how to fall safely.
Like judo.
A bit like that.
Yeah.
How to roll to absorb impact rather than shattering a hip. And crucially, they teach the specific biomechanical steps required to get back up from the floor independently.
Oh, because if you can't get up.
Then the immobility spiral starts immediately. This directly combats the kinesiophobia we discussed earlier.
The fear of movement.
Yes. If a patient knows they can get up, the paralyzing fear of falling begins to recede. They start moving again.
They break the immobility spiral by restoring confidence.
Yes, confidence is medicine. But neuro-PTs also perform incredible interventions for things like freezing of gait.
We talked about how freezing happens because the signal gets jammed in the basal ganglia.
Right.
How on earth does a physical therapist unjam a brain circuit?
By creating external cues to build a neurological workaround.
A workaround.
If a patient's feet are frozen to the floor, simply telling them to step forward often fails.
Because the circuit is broken.
Because the internal brain circuit responsible for generating automatic movement is irreparably damaged. But if the PT places a bright piece of tape on the floor right in front of their feet and says step over the line, everything changes.
But why does stepping over a line work if stepping forward doesn't?
Because it shifts the mental task from an automatic motor function to a visual spatial task.
Oh.
This uses a completely different intact neural pathway in the brain, the visual cortex, to send the signal to the legs, entirely bypassing the damaged basal ganglia.
That is absolute brilliance.
Suddenly, the patient lifts their foot and takes the step.
It's like finding a hidden backdoor in the brain's programming.
It really is.
If the main highway is blocked, they just build a detour using the eyes. That's incredible.
It's transformative for mobility.
And then, beyond the body, we have the physical environment itself, the house with the weak foundation.
That is where the occupational therapist, the OT, comes in.
Okay, what does the OT do?
Their job is to rigorously modify the environment to mitigate the risk of those storms. They are the architects of safety.
Like putting padding on the corners.
Much more comprehensive. They conduct exhaustive home safety audits. They aggressively remove the loose throw rugs that cause tripping.
Right.
They install heavy-duty grab bars in the bathroom. They recommend shower chairs so the patient doesn't fatigue while bathing.
Conserving that energy reserve?
Exactly. They adapt the very utensils the patient uses to eat.
Like special forks.
Yes. Perhaps prescribing weighted spoons to physically dampen the tremor so the food actually makes it to the mouth, preserving nutrition.
They ensure the environment is supporting the patient's survival rather than constantly threatening it.
That's their entire mission.
So you have this incredible, diverse team working furiously to maintain the foundation and patch the roof. The neurologist, the SLP, the PT, the OT.
The whole squad.
But we have to talk about the umbrella term for this kind of comprehensive quality of life focused medicine because it carries an enormous amount of heavy, often misunderstood baggage in our culture.
I know exactly what you're going to say.
We need to talk about palliative care.
We absolutely do. Because the misunderstanding of that term is a barrier to life-saving care.
I know from talking to friends and family, when people hear the words palliative care, they immediately universally think of hospice.
They do.
They think of the absolute end of life. They think it means the doctor is throwing up their hands, giving up, shutting the door, and just prescribing a morphine drip until the monitor goes flat.
If we connect this to the bigger picture of medical history, that misconception is arguably one of the most tragic, self-defeating barriers to effective neurodegenerative treatment today.
Tragic how?
Palliative care and hospice are not the same thing. They are not synonyms.
Okay, clarify this for everyone listening.
Hospice is a very specific, limited type of palliative care designed solely for the very end of life, usually the last 6 months, where all curative treatments are intentionally stopped.
So hospice is the final chapter.
Yes.
What is palliative care, then?
Palliative care, as a broader medical discipline, is simply specialized medical care focused entirely on providing relief from the symptoms and stress of a serious illness.
Symptom relief.
It is completely independent of the prognosis.
So it's about aggressive symptom management, not just sitting in a dark room waiting for the end.
Exactly. Palliative care can and absolutely should begin at the very moment a patient receives a Parkinson's diagnosis.
Right away, day one.
Day one. It runs parallel to the standard neurological treatments. If a patient is diagnosed and is immediately struggling with crushing anxiety about the future,
Which is very common.
or severe physical pain from muscle rigidity, or debilitating sleep disturbances, the palliative care team steps in to address those specific issues aggressively.
They're treating the human, not just the dopamine deficit.
The singular goal is to maximize the joy and quality of life every single day.
And here is the truly profound realization that ties this all together. By relentlessly maximizing the quality of life, you are intrinsically delaying the fatal complications we've been discussing for the last hour.
Yes, you see it now.
If a palliative care PT keeps the patient moving confidently, it delays the immobility spiral and prevents the blood clots.
Exactly.
If a palliative care SLP manages their swallowing with thickened liquids, it prevents the aspiration pneumonia.
It prevents the storms.
Palliative care isn't about surrendering to the disease. It is the active, aggressive strategy of keeping the patient strong enough and nourished enough to survive the storms.
Precisely. It is highly proactive, forward-looking medicine, not reactive despair. It is building the strongest possible shelter around that degrading foundation.
I really want to emphasize this point to you listening right now. If you are tuning in because you are a caregiver to a parent, or maybe you are a patient navigating a scary new diagnosis yourself, or perhaps you are just a curious learner trying to understand the incredible fragile mechanics of the human body.
Everyone can learn from this.
Understanding this multidisciplinary defense is incredibly empowering. It takes a terrifying monolithic diagnosis, Parkinson's disease, that feels like a looming shadow, and breaks it down into distinct, actionable components.
It demystifies the monster.
It means you are never helpless.
Right.
There are tangible, physical, environmental strategies that can be deployed today to alter the long-term trajectory of the disease.
That is the ultimate empowering takeaway from all of this clinical data. Parkinson's disease creates a difficult landscape of elevated risk, but it absolutely does not dictate your inevitable path through that landscape.
Right.
By deeply understanding the mechanics of the risks, the silent dysphagia, the physics of the falls, the biological reality of frailty, you can actively chart a course around them.
So, to bring all of this together and synthesize our journey today,
Let's do it.
we started this deep dive with a heavy, frightening question. Can you die from Parkinson's disease?
The big question.
And the answer is beautifully nuanced, but profoundly important for anyone touching this disease to understand. Parkinson's disease might build the dangerous maze, but it is the complications that actually trap the patient.
Yes, the high-impact falls, the silent inhalation of water, the devastating immobility spirals, the systemic infections bred in a stagnant bladder.
Right. The dopamine depletion slowly weakens the foundation of the house, but the storms are what bring down the roof.
Well said.
By deeply understanding the crucial difference between dying from the disease and dying with the disease, patients and families can anticipate those silent complications years before they happen.
Anticipation is key.
They can enlist the SLPs to protect their lungs, the PTs to protect their bones, the OTs to protect their environment, and the palliative care specialists to aggressively protect their joy. They can fight back.
And fighting back effectively requires exactly what we set out to model today. Looking past the surface symptoms.
Yeah.
Applying critical thinking and demanding a broader, more mechanical perspective on health turns an overwhelming, frightening medical diagnosis into a series of highly manageable, targeted actions. We move from paralyzing fear to empowered strategy.
We move from the muddy, terrifying waters of the unknown to a clear, brightly lit plan of action.
Exactly.
I want to leave you with one final new angle to ponder based on the incredible biology we've uncovered today.
What's that?
If we know that the greatest, most lethal threats in a progressive disease like Parkinson's are actually things as completely mundane as gravity and our own daily meals, the risk of tripping on a rug, the risk of drinking water too fast, how might that reality change the way we look at our own lives right now?
That's a profound thought.
How might that change the way we proactively design our homes, our dining experiences, and our daily fitness routines as we age, even if we are lucky enough to never face a neurological diagnosis?
Everyone ages. Everyone's foundation shifts eventually.
Exactly. What if designing for the extreme, magnified vulnerabilities of Parkinson's is actually the ultimate blueprint for living safer, stronger, and longer lives for all of us?
A blueprint for resilience.
Until next time, keep diving deep.